শুভ সন্ধ্যা। ফিজিও নিউজের সাথে আমাদের সাথে যারা আছেন দেশের এবং দেশের বাইরে সবাইকে স্বাগতম জানাচ্ছি। বিশেষ করে আজকে আমাদের ফিজিও নিউজের আজকে একটা বিশেষ দিন। বিশেষ করে আমি যার কাছে আসলে এই ম্যানুয়াল থেরাপির হাতে খড়ি, আমি সেই স্যারকে আজকে পেয়েছি আমাদের সাথে। তো সবাইকেই স্বাগতম জানাচ্ছি। খুব বেশি সময় নষ্ট করব না এবং আমি ইংরেজিতে চলে যাব, কারণ আমাদের সাথে আরো 8টা দেশের পার্টিসিপেন্ট জয়েন করেছেন। তো তাদের সুবিধার্থে আমি ইংরেজিতে চলে যাচ্ছি স্যারকে। তো thank you everybody and good evening everybody, and today it's a great honor and great surprise for us because I have got my mentors in manual therapy, Dr. Umasankar Mohanty. No need to introduce him because already he is very common face in this not only this subcontinent, all over the world, and he is the ex and the best president in IAP, and also my mentors in manual therapy, and my manual skill that was born, I think, from 2009 in MTFI Mangalore, and I have learned the basic from him, and I always weigh him, and he is my dream sir, and I'm very glad that is on my request he is now on our platform, and I think it's a great honor for us, and everybody please keep do attention, and he is doing some magic today, and I will just go and request sir, please sir, start your session now. Thank you, sir.
So, thank you, Dr. Santanu, for your nice introduction. And I appreciate Dr. Samim and Physio News 24 for organizing this event. And very good evening to you all. It's evening in India, and if you are in any part of the world, if it is morning, if it is afternoon, so my good morning, good afternoon, and good evening, depending on your time zone. And so today I'll be talking about manual therapy for the cervical spine, and I will appreciate that if you have got any query, you can just write it down, and towards the end we will be having one question answer session, so that I request Dr. Santanu to help me out to read out your question, and then I will answer all your queries. So maybe I will suggest you that if you have some a notepad or some paper pen with you, that will be good. And most of the session initially I'll be covering a little bit of theoretical aspect, and after that I'll be doing the practical demonstrations, and I hope that it will be useful for you. So, right. So manual therapy for the cervical region, unraveling the mechanical enigma. So the cervical disorders are very common, and it is rivaled only by low back pain and osteoarthritis in general. And in the present times, because of use of mobile phone, the incidence of neck pain have actually increased. The international figures indicate that at any point of time, approximately 10 to 15% of the population will be suffering an episode of neck pain, and 40% will suffer neck pain during a 12-month period of time. Neck pain is a musculoskeletal disorder, and as I just mentioned that among the musculoskeletal problems, the low back pain is extremely common. And as a physical therapist, after neck pain, after the low back pain, I think neck pain is something what we frequently come across. And it's a common cause for patients seeking treatment from healthcare providers, and the reference is there. What is the prime cause? As I was just talking about in the COVID-19 time, majority of us are due to the lockdown, we are many times at home, and one of the prime work what everybody does is using the mobile phone or or the computer. So prime cause for this neck pain is poor body posture. as well as poor design of the workstation. That is why ergonomics is so important. Not only we do the evaluation, and I'll tell you to all the viewers who are listening to me that many times the patient may comes to us and then we do the assessment, we do the treatment, but again after some days you will see that the person is again coming back. So that is the time while we are doing one evaluation treatment plan, it is essential that we should also evaluate the workstation, and it may not be practically possible for us to do one visit because if you are seeing so many patients, there may be some ethical issues also. So what you can ask them is that you can tell them to take some photograph of their workplace. That is what I do in my practice. I tell them that whenever you are doing your work, you take the various angular photograph and then that or a videograph, and then you can do the analysis and see what is the kind of faulty posture the person is adopting, and depending on that we have to make the necessary workstation design correction also. May lead to, you see that poor body posture and then the poor design of the workstation may lead to muscle pain, particularly in the shoulders, in the neck, the lower arms and the wrist, which if not attended to may develop into something called as the repetitive strain injuries. And prior to it, many of them will be having the trigger point in the muscles also. And the trigger point in the muscles, the joint involvement, the trigger points leading to the headaches, and that is called something called as cervicogenic headaches. And many in the present times, we see many patients, they come with cervicogenic headaches. And alarmingly, for the statistics, 30 to 50% of the general population suffers from neck pain annually, with a point prevalence of around, this is the epidemiological data, with a point prevalence of around 15% in males and 23% in females. The incidence of neck pain is more, if you see the gender analysis, it is more common in the females. And same thing with I was studying some recent research publications about the cervicogenic headaches, and there also the incidences of cervicogenic headaches are very high for the females. And there are so many other issues into the factor of hormones, prolactin, and so many other factors are there. So if somebody is doing an intricate analysis of this research work in cervicogenic headache, then you can and the International Association of Study of Pain is doing some great job related to cervicogenic headaches, and these numbers are increasing with time. And this is the bifocal posture. As you can see here, what is the bifocal posture? That I will be doing some practical demonstration. That time I am going to do a demonstration of the models for a more better and clear understanding. You can see here the head is forward compared to the cervical lordosis is increased, and this kind of and this leads to this bifocal posture lead to one common muscular imbalance, and that is called as upper cross syndrome. And if you can see the cursor, you can see the upper cross syndrome. We have this cross of muscles. This is upper cross syndrome is explained by one Czechoslovakian neurologist named Vladimir Janda. That is Janda's classification, a functional classification of the muscles. He classified them as postural muscles and the phagic muscles. And here you can see we will have the tightness of the upper traps, tightness of the pectoralis major and minor, and weakness of deep flexors and scapular retractors. And maybe a lot of research works are going on, a lot of publications are there in the recent time related to the pressure biofeedback unit during the activation of the deep neck flexors. That I'll be covering in the later part of my practical demonstrations. So it's a bifocal posture. And this is one of the prime cause for the neck pain and for the cervicogenic headache to arise. And cervicogenic headache I was talking about. So it is one unilateral headache localized in the neck or occipital region, projecting to the frontal and temporal regions. And it was explained as earlier 1926, but it was more elaborately explained by Janda et al. In the year 1998. So one can reliably delineate cervicogenic headaches from primary headaches and migraine. Migraine is like one tsunami. There is a difference between cervicogenic headache and migraine. Migraine is like one tsunami. The tsunami, there is no specific cause. It's a Japanese word, tsunami. It arises, you might have, in the news, sometimes tsunami arises and then the sea level goes up and leading to the it affecting the buildings and lives of many people. So same way, it is like one tsunami which can arise without any specific cause. It can arise at any part of the brain. But whereas cervicogenic headache is unilateral headache. Now suppose we have got right side facet involvement, right side sternocleidomastoid trigger point, right side trapezitis. So most likely we are going to have the cervicogenic headache in the right side. That is a classical history from which we have to differentiate from cervicogenic headache from migraine. The presentation of cervicogenic headache, as I just mentioned, as explained by Janda et al. In 1998, muscular trigger points are usually found in the suboccipital muscles and in the sternocleidomastoid, in the upper traps. So these muscles, this trigger point often leads to the cervicogenic headaches. And this is how we identify. This is the pincer palpation. Grasp, and we are grasping the muscle anterior posterior. So you can see here, I'm identifying a trigger point for the upper traps. The clinical test to identify the trigger point is called a jump sign. And wherever there is a trigger point, we have several C fibers. They arise from that particular point. And you know, the C fibers are polymodal fibers. And that particular point becomes intensely electrically active. So when we palpate with the pincer grasp, as I just mentioned in the previous video, when you palpate and due to the intense pain, the person jumps. That is called a jump sign. And this is a kind of, I was talking about the muscular imbalance, which is common because not only the cervical spine, there are recent research publications related to that neck pain, shoulder and thoracic spine, and related to neck pain, cervical involvement. If you do thoracic manipulation, there are improved outcomes related to the cervical pain. So this was the upper crotch syndrome that not only that think globally, act locally is the one adage, English adage one goes. That's why when we are doing the evaluation, we have to evaluate the person as a whole, and then we can go for the specific management problems. This is the upper crotch syndrome as explained by Vladimir Janda, as I mentioned, where we have got tightness of upper traps, pectoralis major, pectoralis minor, levator scapula, weakness of the rhomboids, serratus anterior, middle and lower trapezius, and deep neck flexors. So to be more particular, what are the deep neck flexors? Rectus capitis anterior, rectus capitis lateralis, longus capitis, and longus colli. And these muscles we have to activate. I'll be showing towards the end one practical demonstration of using the pressure biofeedback unit, where I had the opportunity to get trained under Professor Gwendolyn Juul. She is one of the renowned authority related to the neck pain weakness and pressure biofeedback unit. A lot of studies they have done with Falla and Gwendolyn Juul. This is one very important point to remember. For proper functioning of any region, we need to evaluate. This is a stability model, which was given by Punjabi and White, especially for the spine dysfunctions. But for any region, we need to have proper articular component, that is the passive component. Articular component is the passive component, active component, and neural component. So this is a very fundamental way of doing the assessment, because whenever you are doing the evaluation, we have to evaluate, as far as the manual therapy is concerned, we have to evaluate primarily the passive component, that is the skeletal component. And next, that is the active component. What gives the dynamicity to the skeletal component is the muscular component. And next, the fine motor control. Now we read a lot of research publication related to the neuroplasticity and related to the fine motor control, the central processing mechanism. So I think this component, these three components together, that leads to a proper stability component. So while we are doing the assessment, we have to see the passive component involvement, that is a joint involvement, whether it is a disc involvement, it is a facet involvement, or it is an alignment issue, it's any deviation around any of the axis, that is the articular component or the passive component. That is we have to move from gross to finer when we are doing the rehabilitation. And next is the muscular component, and next is the neural component. So this is one interesting slide where it is showing the attachment of the suboccipital muscles. So when we talk about the suboccipital muscles, we have got obliquus capitis superior, obliquus capitis inferior, rectus capitis posterior major, and rectus capitis posterior minor. So these are the prime 4 suboccipital muscles. Out of this, the most important one is the rectus capitis posterior minor. This is a small muscle, but very significant because it is attached to the dura mater. So if the suboccipital muscle is tight, it is going to pull the dura, and when the dura is getting pulled, it is going to impede the or cause restriction of the venous transportation inside the cranial cavity, and that may lead to exertional headaches. This is the passive component I was talking about. How is the alignment of the cervical spine? This is the C0, C1 joint, convex and concave. This is the C1, C2. It's a biconvex joint. And we all know that in the C1, C2 region, we have got the maximum rotation movement happening. And whenever we are dealing with the manual therapy of the cervical spine, we have to be extra cautious because there are a lot of publications in various journals related to the adverse effects what can arise primarily due to the thrust manipulations. That is why we have to be extra cautious about the vertebral artery. The vertebral artery is one tributary of subclavian artery, and it enters the C6 transverse foramen, comes out through the C2 transverse foramen, and then takes move little laterally and upwards. Then it comes medially and upwards. Then it enters the foramen magnum, and near cerebellum it forms the basilar artery. Both the side vertebral artery it combines to form. So it has got different parts. The part 3 gets maximally compromised. So we have to definitely, going for any mobilization manipulation for the cervical spine, we need to examine the vertebral artery and by one VBI examination. And this is the facet joint. You can see this is the synovial fold and this is the facet joint. And inside the facet we have this large synovial fat pad. And sometimes due to some sudden movement, some inappropriate positioning, these meniscoids can come out of the joint. It can cause extra articular entrapment. Capsule is there. So what we do, you would have, these are called as meniscoids also. This is called as a synovial lined fat pad, or it is called as meniscoids. So when it comes out with the gentle mobilizations, we can put back the meniscoid to its original structural and functional position. The cervical facet joints. You see the cervical facet joints and their orientations. Cervical facet joints, otherwise called as cervical zygapophyseal joints, and they are well documented that it can be possible source of neck pain, and it has been hypothesized that pathology condition related to so-called meniscoids within the zygapophyseal joint may lead to pain. And cervical spine function, it is having a great deal of mobility. And this is the C1, C2 region. This is the transverse ligament. This is the odentate process. Just putting little bit of anatomical background before I'm doing some more practical demonstration. This is the pain pattern of the various joints involvements of the cervical spine. Okay, this is one interesting observation. Sometimes you can see that a person is having a prominent line or crease, and above that and below that. Now, when we have this kind of presentation, which is quite common, this is the area of hypermobility, and above and below, there will be a tendency for hypermobility stiffness. If you find this kind of presentations, you need to definitely mobilize the joints below and the joints above, because this is one extrapolation of the Frick's laws. So Frick's law 4, that if any particular area there is a hypermobility, it has to get compensated. So if it is one corollary of that if you have got any area of hypermobile, and above and below that there will be a tendency for hypermobility and stiffness. Another important thing to observe, people, this area appears to be swelled up. People think that it is fat pad accumulation. It is not fat pad, because in between these various soft tissue layers, we have the flow of the lymphatics. Now what happens, suppose there is a hypermobility, the lymphatic flow is getting restricted. And because of lymphatic stasis, the area gets swelled up. It is not fat pad, it is primarily due to lymphatic stasis. More closer view of it. This area of hypermobility, above and below, there is a tendency for hypermobility and stiffness. It's a side view. And checking for the various movements, routine movements, we are supposed to perform flexion, extension, lateral flexion, rotation. But most important movement is the combined movement pattern. That I'll be showing one slide here also and doing the practical demonstration also. And then in the part of examination, we have to go for cervical PPIVM. You see the passive physiological intervertebral movements. The mid finger is placed in the interspinal space. So what we are doing in PPIVM is passive physiological intervertebral movement. You just saw the video. I'm placing the mid finger in the interspinal space, index and ring finger I'm placing on the facet joints. Then I'm taking it for flexion. While taking it for flexion, the facet joints are opening up. While I'm taking it for extension, the facets are approximating. While I'm taking for side flexion, same side there is approximation, opposite side there is opening up. Whenever we are taking for rotation, same side there will be approximation, opposite side there is opening up. Now what happens, if we are able to feel the movement, that means the joint is absolutely fine. If you are unable to feel, that means there is some dysfunction of the joint. I repeat. Now suppose while you are doing the PPIVM for C5, C6, the person in side lying position, mid finger in interspinal space, index ring finger is placed on the facet. While taking for flexion, we are finding the joints are opening. Extension, the joints are approximating. Now C5, C6 you are able to appreciate, but for C4, C5 you are unable to appreciate. That means C4, C5 is affected, because if the joint is affected, the surrounding soft tissues are going to get adhered. Now when there is adherence, that is going to impede or restrict your palpatory findings. Now next step is PAIVMs, passive accessory intervertebral movement. Now there is a great reliability about the palpation of tenderness over the zygofacial joint, and the reference is here. And I'm playing the video.
That is C1, C2 joint complex.
Now what I'm doing is, when you are palpating, I'm taking the tip of the thumbs and I'm palpating the joint. And say for example the COC1 joint. And when you are listening to me, maybe let us do one small practical palpatory session. From your external occipital protuberance, you just palpate down. And you can find the fast bony prominence. The posterior aspect, of course, external occipital protuberance is in the occiput. In the posterior aspect, you palpate down. The fast bony prominence is the C2. Between the occiput and C2, you can find there is a gap. From the gap, if you palpate about 1 inch lateral and about 4 millimeter upwards, you place your palp of the index there. You poke the chin out and tuck the chin in. You poke the chin out and tuck the chin in. You can feel the movement, that is the occipito-atlantal joint. Posterior arch of atlas, about 1 inch lateral and 2 millimeter down. You just rotate to right and rotate to left. You can feel the movement there. That is the C1, C2 biconvex joint. And from C2 spinous process, you palpate about 1 inch lateral and about 2 millimeter down. You can palpate for the facet joint. So why I told about this palpatory landmark is that when you take these palpations, you place your tip of the thumbs and you are giving the posterior to anterior glide. Of course, you have to support the soft tissues. You are giving posterior to anterior glide. Say you are giving the glide for right side COC1 joint. It is not producing pain. But you are giving the glide to left side lateral PA glide and it is producing the pain to the COC1 joint. Right side, no pain. Left side pain is produced. That means that left side joint is affected. Another example, say left side C5, C6, you are palpating. From C5 spinous process, 1 inch lateral and 2 millimeter down, you are palpating for C5, C6 facet joint. And you are giving the glide. No pain. But for the right side, C5 spinous process, 1 inch lateral, 2 millimeter down, C5, C6 facet, you are giving the glide. Pain is produced. That means that right side C5, C6 is incriminated or it is affected. Because it is normally a non-affected side, If it is not producing the pain, it is not affected. If it is producing the pain, it is affected. It's like a confirmatory litmus test. And as I was talking about the VBI, vertebrovascular insufficiency, this is the way you can go for the VBI test.
There are any nystagmus. Next technique is sustained rotation left or right. I'm just going for the right side of the leg. So, spine of the sustained rotation right side. Order for 10 seconds. The next sustained rotation right.
So whenever we are going for the test, the hemodynamics of the vertebral artery gets maximally compromised in extended and rotated position. There are in vivo and in vitro studies related to the vertebral artery, and publications of real-time ultrasound studies are there, and we have also done one of the studies which I'll just show it to you. How we are checking the real time by using the Transcranial Doppler. You can use the Transcranial Doppler to identify the extent of hemodynamic compromise. And what is the presentation? Dizziness, diplopia, dysarthria, dysphagia, drop attacks. 5 Ds of command. In addition, we may have nystagmus, metallic taste in mouth. So if any of these, we have to maintain that position. And if we are doing, there are 12 prescribed tests, but if we are doing at least one test, that will be extension and rotation. Minimum duration we have to maintain is 10 seconds and maximum duration is 40 seconds. And if the symptoms still appear earlier, we have to stop immediately. And if VBI is present, then you should never apply the rotatory thrust manipulation, because that may lead to vertebrovascular strokes. And this is the Transcranial Doppler. I'll show the video for you. You can hear these sounds. That's the systolic, and you can see here these. So with the Transcranial Doppler, we can see that if there is stenosis in the real-time position, then the amplitude will be, it can measure the systolic velocity, diastolic velocity, mean systolic velocity, mean diastolic velocity. It can measure the latency, and it can measure the amplitude. So these are the components we can measure real time, and it will tell you that to what extent there is compromise in the vertebral artery. And that is the diagnostic test. Suppose you have suspicious of any of the clinical findings. And clinical findings, if you don't have a Transcranial Doppler, no problem. Clinically, you can just identify if you have got dizziness, diplopia, dysarthria, dysphagia, drop attacks. And this is one kind of, if it is compromised, then you should never proceed for rotatory manipulations. Okay. Now, what are the important mobilization techniques?
The mentally stabilized.
This is a very useful technique, but VBI testing has to be done a priori. Occiput is supported. Index mid finger anterior to the mental tuberosity. So this is the epi glide, a very useful technique. If you have got this is the suboccipital muscles I was talking about. Obliquus capitis superior here, obliquus capitis inferior, rectus capitis posterior major, and rectus capitis posterior minor. Now, if you have got this suboccipital tightness, and let us do one small experiment. You just, while you are listening to me, you take your 4 fingers. If you are using the, whichever hand is free for you, definitely many of you are watching through the mobile phones, and whichever hand is free for you, you take at the external occipital protuberance, and just below you keep palpating the midline, and palpate the C2 spinous process, and the gap I told you, that posterior arch of atlas, just half inch lateral, any side, right or left. You just place these 4 fingers, and then you just poke the chin out and tuck the chin in. Poke the chin out. If you can palpate with both the hands, that is more better. If you cannot, that's at least one side. Something is better than nothing. So you just poke the chin out, you can feel the contraction of these suboccipital muscles. Now what happens if the suboccipital muscles are tight? That is going to produce, that is going to produce the bifocal posture, which earlier part of, I show you one slide. The head is translating more forward. So when we are giving this AP glide, mobilization AP glide, it is opening of the joints, and also it is going to do an indirect release for the suboccipital muscles. So it's a very, very effective technique. And this is one muscle energy technique for the suboccipitals, where we have to stabilize the C2 spinous process, and my other hand is at the occiput, and then I'm asking the person to poke the chin out while I'm going to give the resistance, maintain it for 6 to 10 seconds and repeat it for 6 to 10 times. And we can go for the cranial base release technique, which is very, very effective. It's a part of the craniosacral therapy. 4 fingers are placed at the occiput, and slowly you can just apply the force posterior superiorly, go to the barrier, and then maintain that position for 6 to 10 seconds, or till the time you get a spontaneous release. Right. See the placements. Occiput, basi occiput region, applying the force posterior and superior, engaging to the barrier, and then maintaining it for 6 to 10 seconds, and we can repeat it for 6 to 10 times, or till the time we get the spontaneous release. And this is the high velocity thrust technique. And as I told you that we have to be very cautious. If VBI is there, we should not go for this rotatory manipulation, the multiplane adjustment manipulation. Rotation to opposite side. Now these are the cavitations, and there are publications which have found out that after the cavitation, the joint play increases by nearly 30 to 35%. If somebody has got some kind of stiffness, obviously with the manipulation, the joint play is going to get restored. And that is going to restore the altered arthrokinematic reflex. The next is HBT in a sitting position. You can do the manipulation sitting position. Primary leverage of rotation to opposite side. So we have downslope manipulation, we have got upslope manipulation, we have got downslope manipulation, we have got upslope manipulation. We have to examine what is our requirement. Where is the restriction? Is it restriction towards the upslope or restriction towards the downslope? So depending on the requirement, we have to apply the thrust technique. But these are multiplane adjustment. So if you are just watching this, so I will advise you not just to, out of over enthusiasm, not just to apply, because there are a lot of cautious things which has to be taken. A proper skilled has to be acquired. So if you are skilled, absolutely no problem. But if you are not skilled, any harm happening, I am not responsible. So I think I just in a more lighter sense, I'm just sharing with you all. So maybe what I'm trying to say is that you have to have a judicious knowledge and practice before you go ahead with these especially multiplane adjustment manipulations, because the scope of work is very less. And then I was talking about this upper cross syndrome. Obviously, we have to check for the kind of imbalances if you have, because shoulder, thoracic, and the neck function, they're very much correlated. So you have to check for that, and you have got tightness. You have to go for the muscle MET of that, and pectoralis minor also is the same thing, small muscle but very significant. You can go for that, and you can see this pectoralis minor muscle. one cadaveric analysis was done by these authors. They published in Physical Therapy Journal, and you can see here with the abduction, the pectoralis minor muscle. With the abduction, the pectoralis minor muscle is getting lengthened. So, and if the muscle is tight, one derivation we can do, if the muscle is tight, it is going to cause the impingement syndrome. So let us do one small experiment. While you are sitting, just go for abduction, sit straight and abduct your shoulder. Then what you do, you just protract and depress your scapula, and then you do the abduction. You see the abduction movement is going to get restricted. So this is how we can check for the length of pectoralis minor, and we are applying the muscle energy technique for that. Similarly, you have to examine the traps, upper traps, and you can you have got the tightness, trigger points. You can go for MET and MFR techniques. So similarly for the sternocleidomastoid, you can go for the MFR techniques and MET. Levator scapula, something very interesting muscle attaching from C1 to C4. Transverse process and to the superior angle of the scapula, and it will have, I'll show on the model that where we are getting the exact pain sites. So levator scapula, similarly we have to examine for the scalene, and the pain may be how manual therapy helps. The pain may be relieved by manipulation treatment by restoring the joint play as I mentioned, and meniscoid return back to its original position if it is displaced. And this is the tensegrity model. I was talking about that passive component, active component, neural component. So we have to make the balance of all those components. That is the tensegrity model. And I just share with you one, before I go ahead with the practical demonstration, the layering patients to find out the extent of involvement. This will be applicable for the cervical spine as well. We are palpating the various layers of the tissues. I am palpating skin, subcutaneous tissue, superficial muscle, and deep muscles. And as I was mentioning that these are between these various layers, we have got the loose areolar tissues. And the extent of these soft tissue dysfunctions, where we, now for any region we are using, because we are in the area of evidence-based practice in EBP, we are supposed to put the things into the statistics. And similarly for the soft tissue involvements, there was for the fascial involvements, there was no grading system, because without any grading system, now I'll give a very simple example. Say neck pain, we are calibrating, we are doing any research work, you have to use say neck disability index, one of the outcome score. In that we are putting the things into the points. Now what is the total outcome score initially, and then after how many days we are given the various kind of interventions, and then we are comparing it. We are putting the things into the statistics, means in the mathematics. Similarly for the soft tissue we did have a system. So I have developed a grading system which is published in my book. I'll be showing towards the end when I'm doing the practicals. The layer 1 is the skin, layer 2 is the subcutaneous tissue, layer 3 is the superficial muscles, layer 4 is the deep muscles with fascia. What are the various grades? Grade 1, adherence of layers 1, 2, 3 and 4. Grade 2, adherence of layer 2, 3 and 4. Grade 3 is adherence of layer 3 and 4. Grade 4 is toughness in deep fascia. And grade 5 is normal. So already our research inter and inter-rater reliability, it is already published in the book, and so many other articles I have already published it. And but inter and inter-rater reliability, we are just finished the work. We will be publishing it soon. So this is the grading system, so that we can like we are checking for the muscles. Checking for the joints, we have got a grading system. Checking for spasticity, we have got a grading system. So this is for the fascial dysfunction grading system. So this is the book, Manual Therapy of the Pelvic Complex. It is available if you can see the Amazon and Flipkart, it is available there. And it is a reference in the, if you see the Wikipedia, there it is also a reference book in manual therapy section. So this is the MFR for the trapezius. You see how the MFR is applied. This is a combined release. Wherever you have got the involvement, about 1 inch above, you have to. So similarly, in the cervical spine, we may come across the cervical disc prolapse cases, and then the prime cause is the flexion, and we have to facilitate extension exercises, and we have to, in extended position, we have to give central PA glides. That is how it is going to help. And I was talking about that deep neck flexors. Along with the mobilizations, you have to go for the stability programs. And this is the pressure biofeedback unit, with which we can go for the cranial cervical flexion test. We can see what extent there is involvement of the deep neck flexors, and we can activate it using the pressure biofeedback unit. So, right, and along with that, along with the physical dysfunction, you have to also go for the thoracic mobilization and manipulation. As well, there are some publications related to it, and how manual therapy helps restoration of joint play and release of minor adhesions, restoration or rebalancing of the arthrokinematic reflex. I just mentioned that arthrokinematic reflex often gets altered, and there is change in the pain threshold. Serum beta endorphin level is increased, and that also contributes for reduction of pain. Triggering of reflex activity due to the manipulation, and physiological changes following the crackling sounds that I already explained, that joint play increases, and the central pain mechanisms, the analgesia due to the long range afferent, that is the large diameter fibers, through the opioid mediated analgesic system, UMAS. And there are, what are the evidences say that multimodal therapy, that is cervical mobilizations and exercises, are more useful as per the systematic reviews. And these are the 2 books I have authored along with numerical other research publications. And this is one of my recent book, about clinical symposia in manual therapy, which includes 16 important conditions. And from the Manual Therapy Foundation of India, which is one ISO 9001-2015 organization. You can visit our website to see the various programs and the activities what we do. And before I go ahead with after this, I'll be just doing some practical demonstrations. I'll just take just a 1 minute break just to get back with you. And we are in COVID-19 time, and it is important to rehydrate ourselves more. So I will suggest you to rehydrate yourself in this 1 minute time. So I'll just enter from the other system.
Thank you, sir. And I will like to request all participants. That is, we need a 1 minute break due to sir will going to directly in demonstration session. Before that demonstration session, I would like to inform you that during our ending session, before ending, we will share our feedback link and throw the link. If you fill up that link, and then you can directly get the certification for today. So we will again share it on our group, respectively on here in Physio News group and also WhatsApp group. So those who are not going to fill up that, then they can fill up it again. But please keep touch on there. Okay, thank you, sir. Over to you, sir.
Yes. So with me, I'm live from Manual Therapy Foundation of India. Just come here. Okay, right. So coming to some of the important evaluations, what we have to do is that I was talking about, along with the observation, posterior observation, lateral observation, anterior observations. Already I have discussed in the slide. Some important tests. See, along with the routine evaluations, extensions. Then I told you that something more important is the combined movement. You see, we're going for extension, side flexion, and rotation. We have the compression pattern, extension, side flexion, and rotation. And this is for the right side and for the left side. See, extension, side flexion and rotation. Now what happens is, if with each movement the pain increase, that confirms articular involvement, facetal involvement. Now, what is the mechanism of it? Now, if the joint is affected, with extension, the joints are approximate. It is going to compress and produce the pain. Side flexion, if it is incremented, compression is going to increase further. Rotation, it is going to increase further. So this is the combined movement test. Very, very important for assessment. And the stretching pattern is flexion, side flexion, and rotation. Now we are doing the stretching pattern for left side. What is the movement? Flexion, side flexion to right, and rotation. That is the stretching pattern. Now, next come to prone line. Yes. So, in subject in prone line position, we have to go for the, see, fingers are interlocked. The lordosis is obliterated. We have to make it in straight position. And palpations. I was talking about my flat palpation grades. You see, I'm moving the skin. Next layer subcutaneous tissue. Next layer superficial muscle. Next layer deep muscle. And we have to see which particular layers are affected. And next one is the various mobilizations. We have the central PA glide. I'll adjust the camera. Yes. Yes. So the central PA glide, external occipital protuberance. This is the C2 posterior arch of atlas, supporting the muscles. See, this is the grade 1. We have to give the grades. Wetland grades. Grade 1, then grade 2, grade 3, and then grade 4. And then the central PA glide. Central PA, normally, if it is not painful, now suppose we are doing the central PA glide for C2, not painful. But for C3, it is painful. That means C3 is affected. And next, coming to this is central PA glide. The lateral PA glide, posterior arch of atlas, I was talking about that. Palpations we have done. 1 inch lateral, about 4 millimeter upwards. You can go for. Okay, this is the lateral PA glide. Right. And similarly, for C1, C2, posterior arch of atlas, 1 inch lateral and 2 millimeter down. You can go for this lateral PA glide for C1, C2. Say, right side we do not painful, left side is painful. That means the left side is affected. So central PA glide, lateral PA glide. And then next we have got the transverse glide. Transverse glide, we have to take the palm of the thumb and lateral to the spinal process and give the glide transverse. That is very, very useful technique. So I just do the demonstration. Just get up, I put on the screen and I just do the demonstration. So that you can see here, this is how we give the central PA glide, the midline, and then the lateral PA glide, you see, posterior arch of atlas, 1 inch lateral and about 4 millimeter upwards, C1 joint, then C1, C2, then we have the lateral PA glide to the facet mobilizations, you see the facet mobilizations, and then the transverse glide. So these are the placements, landmarks for various glides, and I will show you the various important line. Supine, subject in supine line position. Yes, just come up, right? Okay. You see, just lift it out the mask. Distal grasp, you can place it this way and see this, give the AP glide. Right? Yes. So we can go for the AP glide, we can go for the lateral glides. See, we have to hold above the pinna of the ears and then give the glide, relax, relax, relax. And VBI testings, extension and rotation where there is maximal compromise. Minimum duration 10 seconds, maximum 40 seconds. Then I'll show you the generalized manipulation. Anything is there? No problem. So I have checked for both the sides. Occiput, one hand occiput, other hand the chin, rotating, going to the barrier, and then I'm giving a thrust. So that is the generalized manipulation. A specific manipulation, say, suppose I find out that I will take now, I'll show you one technique for the C4, C5 left side involvement. 2, 3, 4, 5. C4 spinous process, 1 inch lateral, 2 millimeter down. Say, I have to give a down slope manipulation. You see, placement, my lateral aspect of the index at the articular pillar, primary leverage of rotation to opposite side, extension, side flexion to same side, go to the barrier and give a thrust. Thrust is applied to the opposite side. Similarly, that is the downslope manipulation. If you have got upslope involvement, say for example the right side C3, C4. Upslope manipulation. Primary lever of rotation, side flexion extension, and thrust is applied towards the opposite side eyeball. Right? So, get up. So these are the important techniques, and I just show you both the books. This is the manual therapy of the pelvic complex, and this is the clinical symposia in manual therapy. And I just go through the cervical spine. You see some important techniques. I'll just show you from my book, Manual Therapy of the Cervicogenic Headaches. And you can see here, just suppose Dr. Basu is helping me along with Dr. Ani. So cervicogenic headache, I have explained what is the difference between migraine and cervicogenic headaches. Already I explained on the slides. So showing you some important techniques what are useful. Cranial based release technique I already covered, and cervical AP glides I just demonstrated. Then lateral PA glides. It's very useful. You have got involvement of those joints. You have to give the mobilizations, and preferably grade 2 and grade 3 mobilizations we have to start. Then transverse glide. It's quite useful. And along with that, the high velocity thrust techniques and the muscle energy technique for the suboccipital. That already I demonstrated while I was showing you the slides. And then the second topic is PM joint. Also, of course, another topic is the cross syndrome. That's what I was interested to show you. The third chapter in my book is the second chapter is the PM joints. Third chapter is, as I told you, there are 60 important topics I have explained. We have got the tightness of the traps, levator scapula, tightness of the pectorals, weakness of deep flexors, weakness of the rhomboids. And we can go for the MET for the pectoralis major, MET for the traps, MET for the levator scapula, then scapular stability training. You can go for the scapular tapping techniques, deep leg flexor. I already showed on the slides. Then we can ask the person to do the chin top exercises, cervical AP glides, AP glide for the humeral head, and then some thoracic mobilization, manipulations, and using a physio ball, you can induce some thoracic mobilization. I'll show you that. You see, this is the pressure biofeedback unit, what we can use to activate the slide down. Go down, go down. Okay. Right. So we have to place it at the suboccipital region. Suboccipital region, and then it is like similar to the one thing we have to do. And then we ask the person to do the chin cup. And here we have got the dial gauge where we have to monitor, and we are asking the person to hold it for 6 to 10 seconds. And we can palpate these various ventral muscles, and they are getting recruited. That is about the pressure biofeedback unit. So I think I'm done with my presentations. I'll take up if any questions are there. Dr. Samim and Dr. Santanu.
Yes, sir. Thank you, sir. Thank you for your nice presentation and nice practical session. Now, already somebody asked some questions, so I will go to the question that is, sir, where your book is available, sir? Is in Amazon or online?
Yeah, online it is available in the Amazon.
Okay.
Amazon, Flipkart, and also they can purchase through Foundation also. Manual Therapy Foundation of India. That option is also there.
Sir, one of our participants asked about that. If a patient come and complain with severe pain and muscle spasm of cervical, in this condition, mobilization is useful for the patient or not?
See, first of all, if severe pain patients are coming, see, it could be due to so many other causes.
Okay, sir.
We have to establish that it is a mechanical problem, because it could be due to meningitis also, it could be due to syringomyelia also. All those cases also, neurological cases also, possibilities are there. So we have to rule out all those conditions. If we find out it, and another important thing is that we need to see the X-ray at least, if not MRI, at least to see one X-ray, just to rule out that if any kind of local pathological condition are existing. I just forgot to just mention, manual therapy is useful for the mechanical problems. And what are the contraindications? The contraindications are like fracture displacements, like any cancer, any severe neurological deficits, and psychological problem, that is yellow flag condition, right? So if it is a mechanical problem, absolutely no problem. We can go for grade 1 and grade 2 mobilization. Absolutely no problem is there. We can give mobilization.
From the first session,
we can give. Okay. Yes. Gentle techniques we can give. And if severe muscular irritation is there, we can go for the positional release techniques for the muscles.
Sir, someone asked about, we can treat the dizziness. Huh?
Dizziness?
Yes.
I can share because dizziness will be due to multiple issues. Dizziness could be due to the vestibular problem also. So suppose we find out that we rule out that there is no vestibular apparatus problem. It is related to joint issues and trigger points also. Joint issues and trigger point also can lead to the dizziness. I have seen a couple of patients where due to facet joint involvement and trigger point, they have dizziness, and with mobilization, they have completely recovered. So if it is not a vestibular problem, because with the BPPV also, benign positional vertigo, also we can get dizziness. So in that case, we have to go for Hall-Pike maneuver and all for the management of that, right?
Okay.
Okay.
Sir, another question is someone asking about the transverse glide. Which joint they can give transverse glide?
Well, it's a very, very nice question. I'll tell you. Now suppose while we are doing the palpation, because the structural alignment, I told that passive alignment of the structure is extremely important. Now, if the C2 is rotated, say, to the right side, C2 is rotated to the right side. It's quite common because people, those who have habit of sleeping in prone lying position, say somebody is sleeping prone lying, rotation to right side, the C2 will be rotating to the left side. And C2 alignment, now if it is rotated to the left side, that means we have to give a transverse glide from left to the right side. And transverse glide techniques are extremely useful, let me tell you, where they are very, very easy to give and they are very effective techniques also. But you should be very sure that if it is around the y-axis, every structure has got 3 axes, 3 planes, 6 degrees of freedom and total 12 movements. Say around the y-axis, we have got the deviation to the left side. That means we have to give a transverse glide around the y-axis to the right side. Due to some reason, if one person erroneously apply the technique to the left, that means immediately the problem will shoot up. That is why one proper clinical reasoning, proper clinical evaluation is extremely important whenever we are going to give any manual therapy techniques, because our scope of work is just 1 to 2 millimeters in the spine.
Yes, sir. Sir, someone asked about your explanation on upper cross syndrome. Which type of exercise they can give?
That already I have discussed. We have to go for MET for pectoralis major, just for another repetition. Pectoralis major, pectoralis minor. Then you can go for stability, scapular stability exercises. As far as the mobilization of cervical spine, you have to give the epiglides. I have already showed that occiput and anterior to the mental tuberosity, you give the anterior to posterior glide. You can give the lateral glides, and you can give the manipulations also. And along with that, you have to go for the soft tissue techniques, MET and MFR techniques for the levator scapula, for the upper traps, for the pectoralis major, for the pectoralis minor, and the strengthening of the scapular retractors and deep neck flexors.
Thank you, sir. Sir, someone asked about how to treat lateral end of scapula pain.
Lateral
end of scapula.
Lateral end of scapula. Okay, that I think yes. So you can go for the positional release technique. You can go for the MFR technique. That would be more useful. Positional release technique and myofascial release technique. Yes.
Sir, in between questioning session, I want to share among the participants, there is a description link, and in our live session, there is a that underneath the search name in the description, there you can find the feedback link, and by filling this feedback link, you can directly get the today's webinar certificate. It is very nice certificate, and sir already give the permission to use his MTFI logo and with his signature, and we think we can this certificate we can use for future in any place we can use for that. Thank you, and thank you, sir. And any other question? Sir, someone asked about your next arrangement on muscle energy techniques or positional release technique.
Okay.
So
we will plan it. They can visit our website www.mtfi.net to see our program schedules. And if somebody is really very keen to learn, I think although I have taken so many webinars, but then what I understand is that what we really learn in the class directly under supervision, because manual therapy is a subject where learning under supervision, because Dr. Shantanu, you have attended our certificate course. I congratulate you. You are one of the first person from Bangladesh to come to Bangalore and attend the course in 2009, I believe. And I'm very happy that you are doing great. But I personally check those gradings. I personally supervise. I personally see the skills, and because that is what is more important. And
yes.
Fine, we'll plan it out.
Yes, sir. I think manual therapy is a totally hands-on approach. So it's online, it not cover anything. I think after Corona program, after coronavirus, this lockdown, if it is finished, then we can arrange any hands-on technique over in Bangladesh again. So it's, I think
Yes,
it's
sir.
already past, yeah, 12, more than 12 years. You have came just before here. So I think we can arrange another hands-on program in Bangladesh also again. So I want to
At
go to,
any part of the world, if more than 30, 40 participants are there, we can plan it out.
yes, thank you, sir.
Huh?
That's true. Sir, we don't have so many questions. Somebody asked about the link. So when they can find the description, underneath the description there is the link for this feedback. So you can click on there and just fill up the questionnaire, and then you can check your email. Maybe your certificate will be there. So if not possible, then we will share it on our that is WhatsApp group or in our page also. So just check on the description. Just please see the description, and underneath it there is a link, feedback link. So you click and fill up that form. That is how is the this workshop, and how's the webinar, your what is your impression, and what is your future plan, and then you can complete it. It is very easy way. So I think, thank you, sir. And there is no more question, I think. So, sir, a lot of people are giving thank to you because some of your old students, those who have attended in Bangladesh before, and they are also thanked you. And I'd like to inform you that is we have 8 countries people with us this time. So I think near future we can arrange some this type of activity again and again, and sir will obviously sir will be with us. And thank you, sir, for this session. I think just we will share our that is link is the main important for us now. So thank you, sir. Thank you.
Okay.
Already you on our list.
So,
Yeah.
so thank you,
Yes.
thank you. I thank all the people who have joined for this session. I hope it was useful for them. I did my best of my efforts, and I should really congratulate to you, Dr. Samim and Dr. Shantanu, for this is one of the very finest platform of webinar I have taken, and I really congratulate you for your efforts. Thank you, one and all. So allow
Thank
me
you.
to sign out. Is that fine? Okay.
Yes,
Thank
sir.
you.
Thank
Thank
you,
you.
sir.
Thank you.
You may go leave, sir. Thank you, sir. Namaste, sir. Dear participants, you will directly go into the description link, or Dr. Shamim will provide you the link on the chat box. Maybe I have to show that chat box is open. Dr. Shamim, you can provide the link on chat box, live chat also. So those people are with us, they can easily fill up that is feedback link.